COPD. There are two forms of COPD. COPD can be emphysema or chronic bronchitis. We are on page 603. Page 603. I repeat, there are two forms of COPD. We have emphysema and chronic bronchitis. Most people with COPD have both emphysema and bronchitis. This is because the number one cause of COPD is smoking. Doesn't matter if it's first-hand, second-hand, or third-hand smoking. First-hand is you're the one smoking. Second-hand is somebody around you smokes, and then you inhale the smoke out from the patient, from that smoker. And third-hand smoking is the smell of the same chemicals on patient's hands or clothes. Okay, and then you're exposed to the same things. That's third-hand smoking. Now go straight to the pathophysiology. The diagnosis of COPD will be measured using, remember heart failure where we had class 1, class 2, class 3, class 4? Okay, so COPD also has the same. For the classification, we will use the GOLD classification. We'll look at that shortly. It's about similar to heart failure, the New York Heart Association classification. Let me just explain FEV1. Now, FEV1 is measured through a series of tests under what we call PFT, a pulmonary function test. Pulmonary function test is done in a doctor's office, whether that office is in a hospital facility or in any other location. We do not do PFTs on a hospitalized patient. Reason is, when a COPD patient is hospitalized, we cannot do a PFT because a PFT needs to be testing the patient's baseline. A PFT done on a sick patient who's in the hospital is not baseline, is it? Is it baseline? No. So therefore, PFTs do not occur in a hospitalized patient. When do we do PFTs? In a clinic, when the patient is feeling well. Okay, so that's the only time we do PFT because PFTs have to be baseline. We need baseline data for that. Okay, so let's talk about how do we develop COPD. Let's talk about emphysema first. Oh, well, bronchitis is mentioned here first, so let's do bronchitis first. Chronic bronchitis. Acute bronchitis is not COPD because the changes in chronic bronchitis is what makes it COPD. Acute bronchitis do not develop any permanent changes in your airway, right? So let's start with chronic bronchitis. First, before we do this, let's look at how your body works. So are we breathing right now? Are we breathing any sterile air? Okay, so the air we're breathing, is it clean or dirty?
I mean, it's dirty.
Oh, it's not like there's mud, right? I mean, generally clean, yeah, but is it sterile? No. Okay. So when you go outside, are you sure that that air doesn't carry any dog poop or cat poop, bird poop? There's all sorts of poop outside, right? And they dry up from the ground, they get washed up in the wind, and it ends up in your lungs, okay? So do we need something to clean our lungs? Yes, that something is called protease. Right, so we have protease in our airway. What is protease? It's an enzyme that cleans our lungs and our large airways. So we owe our health to protease. It's constantly produced. And we also have something called alpha-1 antitrypsin. I repeat, alpha-1 antitrypsin. You'll see it later in the paragraph. What is alpha-1 antitrypsin? Well, if we have protease and the job of the protease is to destroy debris, meaning whatever you inhale, whatever poop, however much poop you inhale, don't worry. Protease enzyme is there to destroy it. So they'll break down debris. Okay, so whatever you inhaled in your airway, protease will digest it. We have to stop protease at some point, yeah? Because when you're at home, are you breathing poop at home? No, your air at home is cleaner than it is outside, yeah? So we need something to stop protease from breaking down stuff. Meaning when it's time to stop, we produce alpha-1 antitrypsin. The purpose of that is to stop protease. Okay, the alpha-1 antitrypsin will say, okay, it's time to destroy you now. We don't need you anymore. We're sleeping. Okay, so get out of here. Okay, they'll destroy protease. And the cycle goes on. Now, what happens if it's a smoker? So let's say you're a smoker. So what are you constantly inhaling all through the day? You lit one cigarette after the next one. Okay, so who knows, right? We have tar there, there's nicotine, all other chemicals in each puff of the cigarette. So will you have increased protease production?
Yeah.
Yes, your body needs more protease. So your body will tend to produce more protease. Are you going to produce more mucus as well? Correct. So the protease production increases and the mucus producing cells also increase in size and number, okay, in response to your constant smoking. The problem with that is, let's start with the increased protease. At night, when you're sleeping, are you still smoking? You have to stop smoking at some point, yeah? You have to go down to bed and then sleep. So when you don't have any more nicotine, but your body continues producing protease, now what happens? What will the protease now digest? That you've run out of, you stopped smoking. It's your fault. It wasn't protease's fault. You should have continued to smoke when you were sleeping. Okay, but then you messed up. You stopped smoking while you sleep. So now protease will destroy what? It will destroy the lining of your airway. So now your airways and even your lungs are going to be destroyed by the protease. Okay, so whose fault is it? The smoker, because they did not smoke while sleeping. Does that make sense? All right, let's go to the mucus producing cells now. So now the mucus producing cells, what is the purpose of mucus? Why do we have mucus in our airway? Mucus, not the, not the cilia. The mucus, no, this one. This one. What is the purpose of that?
Clear the airway.
I'm clearing it. So for production, okay, so any debris will stick to the mucus and then the mucus will be propelled by the cilia, right? We have hair-like projection. So that's the purpose of mucus, to protect our airway from any pollutants. So when you smoke, what happens to the mucus production? Because you're constantly putting pollutants in your airway. So, okay, so the mucus production increases, so will the cells. So to increase production, the cells have to get bigger. Does that continue at night? Yes, because they're so big and they're so active now. So they will continue producing mucus even if you stop smoking in your sleep. So you understand so far? Okay, so what will be the consequences here now? So your lung structures are destroyed, plus your mucus production is increased. What happened to the integrity or the patency of your airway? It narrows. Okay, so now the airway is so swollen, there's so much mucus there, so it will decrease the opening of your airway. So what will the patient manifest now? Will there be coughing? Constant coughing to clear the airway. Plus, will there be shortness of breath? Okay, so that's just a few. Okay, so here now, so there's now the thickening of the lining of your not only blood vessels, but also of your smooth muscle of your airway. And they will develop pulmonary hypertension. What does that mean? Which side of the heart pumps blood to the pulmonary arteries? That right side. So what type of heart failure will these patients develop? They will develop right side heart failure. Is it caused by any of the valve problems, the hypertension? No, this one is caused by pulmonary hypertension. So your smoking does not only cause lung problems, but also heart failure, right? So here's the protease, the anti-protease proteinase or protease, and the anti-proteinase. So the anti-proteinase is the alpha-1 antitrypsin. Okay, this one right here, alpha-1 antitrypsin. Now it's worth mentioning here because there are about 10% of the people worldwide with COPD have never smoked. So those unfortunate 10% have a genetic problem, which is alpha-1 antitrypsin deficiency, meaning genetically they don't have alpha-1 antitrypsin. So therefore, when they produce proteinase, do they have something to destroy proteinase? Do they have anti-proteinase? No. So therefore, do they have lung destruction? Yes, but not due to smoking, but due to a genetic deficiency of the anti-proteinase, which is alpha-1 antitrypsin. Any question? All right, let's move on to, so this is bronchitis now. So this is the shape and thickness of your smooth muscles in your main airway. And this is now a chronic bronchitis airway. Look at the thickness of the wall. Okay, because of the constant smoking, again, the increase in the size of the mucus producing cells, and then the destruction of the structures as well, all lead to this. So how much air can pass through here now? Very little. So when you exert, let's say you're jogging, can that size airway supply the increased oxygen demand? Not anymore. So the symptoms we'll look at clinical manifestation shortly. Let's finish emphysema. So what is emphysema? So chronic bronchitis affects the large airways from your trachea all the way to the large airways in the left and right main stem bronchi. Emphysema is now destruction of the actual alveoli. So this is now in the lower parts of the lung. Okay, this is now involving the alveoli, your air sacs. Same cause, you're smoking, whatever you're sucking, or let's say you're not smoking, you work in a very polluted environment. Okay, same effect as smoking. Say you work in a factory with so much pollutants, for instance. So same as smoking. Okay, you're exposed to pollutants constantly. So this one is now same cause, same proteinase, same anti-proteinase, but this is now involving the lower airways now. So this is now the lower parts of your lung. Here's the picture. So these are now the actual air sacs. So on the left side are your normal air sacs. Okay, they're nice grape-like structures. You have 100 million of these in your body, in both lungs, so about 50 million in each lung. They're supposed to be individual grapes like this. Look what happens if you have emphysema. So not only are the terminal bronchioles distended and flabby, but also the destruction here, there's destruction of the walls now. So instead of being individual grapes, they become one lumpy structure which do not distend or flex anymore. Meaning these guys right here, if you have normal alveoli, they can coil, meaning they will extend and they can relax. Okay, they can do this, right? They can distend to fill with air, and then they can contract to push air out. Here, no, because this is now one flabby structure. And if you have more of these, we call them bulla, bullae for plural. So they become bullae. So meaning they're basically air sacs that cannot recoil. Okay, they cannot push air out. So therefore, here you can inhale oxygen and then you can exhale CO2, correct? On the left side. On the right side, the damaged air sacs in emphysema, yes, they will inhale, they can inhale, fill with oxygen. The problem is, can they push the CO2 out? No. So therefore, is there an imbalance here between gas exchanges? Yes. So think of it as the effects here over time will be like, who snorkels here? Who have tried snorkeling? Okay, Miss Magley, how long can you snorkel? Why do you think that is? Why do you think that is? Why can't we snorkel indefinitely? Because what are you, let's imagine, okay, so let's say this is the snorkel and this is, let's say, Miss Magley's mouth is here, okay, and then this is the snorkel coming out of her mouth. So she's partially underwater, okay, so she's enjoying the fishes and the corals. When she takes the first breath from the snorkel's about what, 6 inches or 8 inches long, right? Okay, so think of it as a really long snorkel. The first time she takes in a breath, what gases did she inhale? There was oxygen, right? There was oxygen in the snorkel. Now, when she took her first exhalation, what was in the snorkel now? CO2. When she takes the next breath, what is she inhaling? The same CO2 and some oxygen. Yeah. So therefore, with every succeeding breath, what happens to the amount of CO2 that she's rebreathing? It increases. So think of it like that. Because these patients cannot get rid of the CO2. It's hard for them to get air out, even harder to get new air in. So now there's a lot of air trapping here. There's a lot of old air left in here, okay, which they cannot get rid of. So therefore, they bring in so little new oxygen. They have so much old air. We call that residual volume. So they have so much residual volume. What you have basically is dead space. Yeah, you agree? Meaning you have so much residual volume, so you can't get new air in. So are they going to be short of breath? Yes, the same effect as chronic bronchitis. Same result. Okay, this one hard, very hard to get air in, also hard to get air out. No different from here. Same exact result. Okay, so let's go to the manifestations. Oh, risk factors first, of course, is smoking. Now, the book doesn't specify whether it's just cigarette smoking. It just says smoking. So whatever you smoke, whether it's marijuana or tobacco, cigarettes, vaping, doesn't say what you're smoking. Okay, so the fact that you're smoking, that means, is there ever a healthy, you smoke what? You smoke Tylenol? No, right? So when we smoke, it's usually something not good. So tobacco remains the number one cause, again, followed by secondhand smoke, and then we'll add third-hand smoking there. Increased age, okay, pollution, same effects, no chemicals, whatever. Let's go now to the, sorry, we already mentioned the alpha-1 antitrypsin deficiency. Okay, so this is the small percentage. Oh, sorry, it's only 2%. I said 10, yeah? No, it's less than that. It's 2% of the COPD population have alpha-1 antitrypsin deficiency. All right, let's go to manifestations now. Now, most of the symptoms mentioned here are chronic, meaning will these ever go away? No, these are day-to-day manifestations. So the three primary symptoms of whether it's from chronic bronchitis or emphysema are chronic cough, sputum production, and dyspnea. How much sputum? It's like this. So I'll just use my late father as an example. He would cough like this. That much sputum. Okay, I would say a cupful. Right? Now, how can you sleep? How can you get any rest? Okay, how can you eat? If you can't breathe, can you eat? All right, so what are the consequences here? Will they lose weight? Are they malnourished? Can they choose to eat or breathe? Can they choose between those two? I think I'll eat today, not breathe. No, you have to breathe. So therefore, when they have acute symptoms, can they eat? No, that's your number one problem. Okay, so if once you can't breathe, can you walk around? So what will be consequences? Will there be immobility? Will there be DVTs? will there be pressure ulcers? All right, so we have all sorts of immobility consequences here because this happens with every respiratory patient, okay? Not just COPD admissions, only also for pneumonia, COVID, any respiratory condition. So those patients who are admitted for a respiratory problem, are they at risk for DVTs? Yes. Now, for a chronic condition like this, are they admitted to the hospital for a chronic problem? For chronic symptoms, rather?
Yeah.
Chronic symptoms. Is there a reason for hospital admission? No, you are, yes, you are admitted for an acute problem. So meaning if these manifestations get worse than usual, then they go to the hospital. Are we clear? Meaning every day, yes, they'll always be dyspneic. Okay, doesn't mean they'll go to the hospital every day. Okay, meaning if they can't breathe anymore and it's affecting how they, their nutrition, their mobility, then they'll be admitted. Okay, so therefore you have to judge, you have to make a judgment on the exam, which were acute symptoms, because you need to be able to teach the patient which are the acute symptoms. That way they know when to call their doctor or when to seek medical attention, right? Because they'll be on, we'll go to management shortly. Here, the problem here is, I mentioned earlier, do you like tables and charts now? Look at this paragraph. It's a jumble of manifestations. Doesn't really tell you, unlike in a table wherein, oh, these are the chronic symptoms and these are symptoms of an exacerbation. It's better like that, right? Here you have to comb through the entire paragraph. Actually, it's just not just one paragraph. It's several paragraphs worth. So if I were you, you create your own table out of the paragraph. Okay. So here, so however, not all people with cough and sputum production develop COPD. Cough may be intermittent or may be unproductive. Dyspnea may be severe, interfere with activities, right? So for example, this one, because of the hyperinflation, look at the picture of your alveoli now. Your alveoli look like this. So what will happen to the diameter of your chest? It will increase. So the barrel chest that they mentioned here on the manifestations in this paragraph, the barrel chest, is this chronic or acute? This is chronic because did this occur overnight? My chest is like this now, tomorrow it'll be barrel chest. No, this took decades to develop. Okay, so this is something chronic, something permanent. What about the clubbing of the fingers? Did you only see clubbing of the fingers here in COPD, or have you seen clubbing of the fingers before in MedSurg 1? You know, some chronic hypoxic condition, heart failure patients, they also have chronic hypoxia. Okay, so those people also have finger clubbing, meaning that's evidence of chronic hypoxia, chronic hypoxemia. So this is the cost now of the barrel chest. It's supposed to be, it's oblong right here. So the transverse diameter is supposed to be twice your anterior posterior diameter. Now it's like a circle. So it's equal now. Now the problem with that is, look at the heart in the center and the lungs here. If it's this shape, your lungs can expand more. However, if you turn it into a perfect circle, what happens to the lung expansion? You have less lung expansion now. That will limit your air intake. I mentioned FEV1 earlier as part of the pulmonary function studies or pulmonary function tests here. Now, the way we diagnose COPD is on FEV1, or forced expiratory volume in 1 second. This means that when you blow into the spirometer, this is the machine that we use. Now, this is not, don't confuse this with incentive spirometer, okay? This is different. This is a bigger machine called a spirometer. So in spirometry studies, you'll be asked to blow into a mouthpiece several times. It's a long hose, and then you'll be blowing into it several times, and they'll record the highest number. FEV1 again is forced expiratory volume in 1 second, meaning they'll ask you to blow as hard as you can, and they'll measure how much air came out of your lungs in 1 second. All right? So the less air came out of your lungs, that means, remember the changes we talked about earlier? No, the flabby. So how much air can you get rid of? You have emphysema? Do you have a lot? No, because you have a lot of residual volume. So here, what will happen to your FEV1 reading? Very low. You understand? So that's why it's a very valuable test. So this will determine how much can you get rid of. Okay, how much, therefore, it will also measure residual volume. Okay, so if you can only get this much air out in 1 second, no, the lesser the number, then the worse your COPD is. And here's the classification somewhere right here. So this is the gold classification, table 20-1. Look at the FEV1, grade 1, you're still at 80%. Okay, look at grade 4, less than 30%. So that means you're retaining 70%. That's a lot of old air left over. Complications, I already mentioned the heart failure that will result. Now, the heart failure resulting from COPD is not called right side heart failure. Although the manifestations are exactly the same, we call it something else. We call it cor pulmonale, right here. Cor pulmonale is heart failure resulting from pulmonary arterial hypertension. Okay, because the pressure in the pulmonary arteries are so high because your lungs are very flabby. Management. Now the management here, the drugs will be found under asthma because asthma and COPD management, medication-wise, is exactly the same. First, risk reduction, we have to tell the patients to stop smoking. Can we tell them to cut down on their smoking? No, cut it down, cut down. Do we tell them to cut down? No, we tell them to stop smoking. Can they stop immediately? Well, that's up to the patient, right? Yeah, of course, it's hard to quit cold turkey, but you give them the resources. Okay, so we have Help NY. Okay, so we have Quit New York. We have so many services in the state. So there's so many ways to quit smoking. We got the nicotine patches. We got the gum. Okay, they even have medications. Okay, they have pills also. But smoking cessation is number 1. Again, we do not say cut down. We say what? Stop. How they stop? Of course, we assist them. Okay, we provide them with the resources. But what's our goal again? Stop smoking. And of course, tell them, it's not just COPD that we're trying to stop here. We're also trying to stop stroke, heart attacks. So here are the other ways they stop. Okay, so we got nicotine treatment in these various forms, and we have these drugs, bupropion SR, nortriptyline. Nortriptyline is an antidepressant. Okay, so is bupropion. Okay, so they help with these are the pills that I'm talking about. Here's another one, varenicline. I forgot this is a very popular option. Forgot the brand name. All right, oxygen therapy. What did you learn in Fundamentals and MedSearch 1 about giving oxygen to COPD patients? Okay, so that's what you learned, right? Why was it again? Why is it 2 liters? What's the rationale for that? Because okay, because they have a different physiology now, yeah? Because they have chronic high CO2 levels, so you don't want to drop it too low, yeah? Because now they respond to low oxygen. Instead of low CO2, they now, instead of high CO2, they now respond to low oxygen. So if you give them so much oxygen, then there's no more trigger to breathe. Yeah. All right. Now take note of what the book says here. All right. Now, does this say here anywhere in this paragraph that you're limited to 2 liters? Does it say anything? That you can only give 2 liters? No, since it doesn't, this is what we follow. Oxygen transport to tissues depend on factors such as cardiac output, arterial oxygen content, concentration of hemoglobin, and metabolic requirements. So, if 2 liters doesn't cut it, and the patient is in the hospital, okay, they are here for an exacerbation, meaning they're having a flare-up, a decompensated state of COPD. Are we limiting them to 2 liters? No. You can give as much oxygen as is needed to maintain oxygen saturation. Our goal here, therefore, however, is not really like normal. Our goal is not 95. If they reach 95, that's great. But our goal for COPD patient is around 90, 92. Okay, 90, 92%, we're happy with that. Are we clear? Right. You're not gonna die at 90 or 92%. That's good, especially for COPD patients. Are we understanding each other? So how much oxygen do you need? You give minimum necessary. Okay, I'm not saying give them 100 liters per minute. I didn't say that. We give them as much oxygen as they need to reach 90%. 90% at, let's say, 6 liters, stop. Okay, that's enough. They're at 90. Don't go for 95. That's not, if they reach 95, great. But do we need to reach 95? Okay, that's not realistic, okay, for most COPD patients, especially for those who've been having COPD for 30 years, 40 years. Okay, we're happy with 90, all right? Of course, as they get better, do we keep them on that high oxygen flow? Of course, if you don't need it anymore, please drop them down back to 2, all right? Are we clear?
Yeah.
All right. What are the early signs of hypoxemia, which are again early, we want to do early so the patient, recognizes that they need to go to the hospital. First sign will be lethargy, confusion, disorientation here, impaired judgment, agitation, disorientation, confusion, lethargy, and coma. Now, are the patients aware when they have these? Like, I seem to have impaired judgment. Are they aware that I seem to be lethargic? No, you're the one, a third person will have to identify that, yeah? Okay. Also chronic changes here, I forgot to mention earlier in the paragraph, besides the barrel chest and the tripod position, they will also have polycythemia, meaning they will appear red because of polycythemia. What is polycythemia? Increase in red blood cells. So they'll have a higher than normal RBC count. So their hemoglobin levels will be higher. So is the hematocrit. Now, this is a compensatory response, meaning because of the chronic hypoxia here, the patient's red blood cell production increases. This is an effort to increase oxygen delivery to the tissues. Okay, and this is normal. This is expected response to someone with chronic hypoxemia like COPD patients. So they may look red than usual. No, they look really like they're flushed. Okay? They will appear flushed. All right, so as with any other patients taking chronic oxygen therapy, so oxygen toxicity is a risk. You may end up giving too much oxygen. So here's the explanation. No, there are free radicals that are released because our body is not used to that high FiO2. Okay, our body is only used to how much oxygen are we breathing today? Like right now? 21%. Okay. So here under oxygen therapy, it tells you here, okay, room air is 21%. Yeah. So that's how our body cells are used to 21% concentration. Now, if you increase that because you're giving oxygen, then there will be risk of oxygen toxicity. Okay, here are your manifestations. So if I put this on a select all that apply question, how do you know that you're giving too much oxygen to a COPD patient? Select all that apply. Yeah, it answers are here, okay? So we already mentioned this earlier. So we use the minimum necessary. So lowest amount of oxygen needed to get a acceptable oxygen level in the blood and to prevent toxicity. All right, the rest are common sense. I mean, if you have oxygen therapy, especially at home, is it important to have no smoking signs? All right, very good. You still remember how much this table, do you still remember from fundamentals, how much each oxygen delivery device can deliver? Now, let's say cannula, what's the maximum you can give there? 6 liters, yeah? Here, for nasal cannula, 1 to 6 liters. And then for the simple mask, 5 to 8. So therefore, if you're increasing the oxygen delivery, do you stay with one oxygen delivery device? No, you have to change, right? Okay. So if I give you pictures, for instance, let's say the patient is using, or the nurse is using this oxygen delivery device to deliver oxygen to a patient with COPD. How many liters should she set the regulator? Then A, B, C, D. Can you answer? Now you can. Okay, so you have table 20-2. All right. So I'll copy this picture here, put it on a test question, and here are your answers. Or also, if you read the last paragraph, advantages and disadvantages. So what's a disadvantage for a mask versus a cannula? Can they eat with a oxygen mask?
No.
They can eat?
No.
How? The mask is here. You're gonna put the chopstick through the hole right here, because there's a hole on the side of a mask. Put the chopstick through there. Can you put the chopstick there? No, right? Okay. What about if the patient vomits? That's a danger. That's a danger, yeah? So these things you consider, right? All right, let's go to the medications. Let's finish first the non-pharmacologic treatment. So this is about oxygen. Let's go to breathing exercises. Oh, well, the drugs came first, so let's do drugs. So most COPD patients will be on 2 types of bronchodilators. We have SABA. You still remember that term? SABA and LABA from pharmacology? Yes? Okay, if not, then let's talk about them. The rescue medications are called SABA. SABA stands for short-acting bronchodilating agents, SABA. And then, of course, if it's LABA, that means they are long-acting bronchodilating agents. Okay. So how do they use them? LABAs are used for what again? Long-term symptom control, meaning these are maintenance medications. Whether they have symptoms or not, do they take them?
Yeah.
Yes, they take them regardless. They do. So they take these types of inhalers, whether they have symptoms or not. Short-acting bronchodilators are used for acute symptoms, meaning they are short of breath now. They already took their LABA earlier. Can they take an extra dose of the LABA? No. The LABAs have a fixed dose. Let's say it says 2 puffs once or twice a day. That's all they get with the LABA. Any additional doses is useless. It will just lead to toxicity and they're wasting the medication. SABAs, however, have more frequencies, meaning they can use this every hour depending on which one they use. Most frequent one, of course, is the albuterol, but we'll look at a few drugs shortly. So which one do they bring everywhere they go? The SABA or the LABA? The SABA. They should have it in their purse, in their pocket, okay, wherever they go. The LABA, they don't have to. I mean, as long as they have access to it when it's due, okay? But let's say they're just out during work, so they can take the LABA before they leave the house and then take it. If there's a second dose, they take it when they get home at night, okay? But the SABA have to be on them everywhere they go, right? So if they get stuck on a train, for instance, they have symptoms, they have ready access to it. Have you ever seen someone die because they can't breathe? Have you ever observed that?
No.
It's the most painful thing to watch, right? And then there's nothing we can do. We have those problems with when the decision makers, no, it's not the patient. The patient didn't set out, advance directives, right? Like what happens to me? Do I get intubated? Do you do CPR? No, things like that. There's some patients who, families that don't understand fully. It's not their fault, but sometimes they don't understand the consequences of their decisions. Because let's say the decision is, okay, no CPR, but then no, sorry, they're full code, right? They have do CPR, but then they have a do not intubate order, meaning do not intubate but perform CPR. Now this is what it's gonna look like. The patient's alive, okay, but they have a hard time breathing. They can't breathe. All we can do is non-invasive ventilation, which is a BiPAP. Okay, we put the BiPAP on the patient, but they cannot breathe. They're like this. But we can't do anything because you said do not intubate. All right. It's the most painful thing to watch. And I can't look at the patient. And the patient's looking at you. They're like, help. But you have a do not intubate order. We can't go against that order. Okay. So you wrote it yourself. You signed it yourself. Do not intubate me. Okay. So sometimes it's not the patient making that decision, it's the family. Okay. So I hope, you guys educate your family members or, explain to them what the consequence is. Okay. No, they have to understand the scenarios, okay, of these decisions. They may sound trivial, but when it comes to the patient, it's most painful thing to watch. Okay? But there's nothing we can do except watch the patient suffocate. Okay, and then we can't do anything until their heart stops. Then we do CPR. But then the problem is, can you do CPR without an airway? See what I mean? Some patients are, no, that's not usually the patient. Most of the time it's the family members. Okay, they don't understand what they're checking. And then we explain, this is what happens. And then they continue to be, just some people you can't educate. All right, so here are the forms. So we have MDIs, and DPIs. So MDIs are meter dose inhalers. You're probably familiar with them. So these deliver wet medications. So they spray a medication. Okay, you go spray, inhale. So that they're wet medications. Now, dry powder inhalers are also inhalers, but they're in a powder form. So these things do not spray the powder. You have to suck the powder in, meaning when you press on the inhaler, you have to suck the medication in. Okay, so you have to suck it as deep as you can because you want the powder to go into your lungs. All right, so that's the difference between the two. We have pressurized MDIs now, which are better because most of these are breath actuated, meaning it does not spray the medication unless you suck, which is better because if you have an MDI and then the patient doesn't know how to use it properly, meaning they go like this, spray, psst, medication already in their face, and then they go, right? Or let's say it's in their mouth, they go, and then, no, wrong timing. So of course the medication's in their tongue, in their gums, it's not in the airway, right? So with PMDIs, now this thing is you can call it a smart thing, okay? Because they don't press the canister. All they do is breathe. When they breathe, then the canister will spray the medication. Okay, so you can call them smart inhalers. All right. Of course, they have a battery in there. Now, PMDIs or especially DPIs may have a spacer. I'll show you pictures shortly. Now, the spacers, right here. This is a spacer, but not all spacers have a mask like this. So some spacers just have a mouthpiece like this one. Okay, I like the mouthpiece better. That way it really goes into the airway, because if you use this one, I mean, the medication still goes in, but it's really better through your mouth than through your nose. Okay, so again, this is a spacer. This is the inhaler. This is the canister. This is the mouthpiece, right? So you put the canister in there. Now, for people who don't have the dexterity, wrong timing, the wrong timing of inhaling, you tell them use this one, because this one, when they press the canister, they can take their time. The medication will circulate through here, giving them additional few seconds. Okay, they can have 4 or 5 seconds to do it. They can take their time to inhale. Okay, meaning if you have a really old person or maybe a very young child, lacking the dexterity, you have them use a spacer. All right. These are dry powder inhalers. So this is what I mean by they have to suck it in. So the faster and deeper they suck, then the deeper the powder will go into the airway. All right. And these are your medications. Table 20-3. Now the drug names are not here because, like I said earlier, it's in the asthma section. The drug names are in the asthma, so I'll bring you there. Let's just finish the non-pharmacologic here. We also have steroids. What did you learn in pharmacology? When they do steroids, inhaled steroids, what should they do after taking it? Okay, good oral hygiene, because what will happen? Okay, they'll have fungal infections. So here are now your exacerbations, what to do. First thing is the recognizing the symptoms. Again, if their symptoms get worse, they're more dyspneic than usual, they have more sputum than usual, or they have different color sputum now. It used to be it's just clear or white. Now it's colored green, orange, brown. This is not right. Yeah. So that's something they have to report. It could be an exacerbation, or maybe they develop a bacterial infection. Okay, these drugs don't have the nursing, this list, don't have the nursing implications. Again, I'll bring you to the asthma section, but at least you know that they're SABA or LABA, right? Table 20-4. Because they all end in roll, okay, but you don't know if it's a SABA or a LABA, all right? So this table tells you. We have anticholinergics. Now, the anticholinergics are chosen because what's a side effect of a beta-2 adrenergic agonist? It has the same effects as epinephrine. Okay, so same tachycardia will result whether you're taking epinephrine or these beta-2 agonists. So therefore, if the patient already has another problem, let's say they have atrial fibrillation, okay, so they're already tachycardic, are these a good option? No, so your option is an anticholinergic. These ones will still open, there's still bronchodilators, but without the tachycardia side effect. Okay, so this will be your option. So either ipratropium or tiotropium. Sometimes the doctors will combine it. They'll combine albuterol and ipratropium together. So there you go. You have a nebulizer called the DuoNeb. Okay, so you have a dual short-acting bronchodilator. So this is a other combinations. So these are very popular. You don't have, this one is Advair. This is the most popular. It's a purple disc. In fact, it was in the picture earlier. Here, this one, this is Advair. This is salmeterol and fluticasone. It has steroid and a SABA. No, sorry, a LABA. Salmeterol and fluticasone. Here, salmeterol is a LABA. So they combine that with a steroid, fluticasone. There you go. You get a long-acting dual medication. We'll skip through the surgical options. Let's do the medications now. Okay, let's go to asthma. I'll just refer you to the drug treatment. So go to asthma and then under medical management, you have the drug list here with the nursing responsibilities. Okay, so table 20-5, exactly the same as what you saw in COPD. Are we clear? Yeah. Page 634, 635, table 20-5. So here are, this list has a complete side effects and your nursing responsibilities. Now for all patients, especially taking inhalers, make sure you teach them how to use the inhaler. Okay, because I tell you 50% of their readmissions is not because they don't have the medication. They have it, but are they using it correctly? No, that's the problem. You'll be surprised how many you'll observe, no matter how long they've been on the inhaler, but they apparently don't know how to use it. So it's they're wasting the medication and they're having unnecessary hospital admissions. Okay. That's it.